January 12th, 2026. We'll poll each member. Dr. Pagan?
Yes.
Dr. Martone? Yes. And I vote yes, so the minutes are adopted. Next, on the agenda today, we have a financial update from the finance team. I'll turn it over to you, Mr.
Yes. Thank you for your time. Nice to see you. So we've been, putting a full court press on trying to get the 5-year financial plan update, to you by the time of this meeting. And, James and Linda and Cliff, we had a meeting with, OMB, and they just asked for a couple more days, to look it over. Our hearing is, I think, a week from today. So we'll have that prepared. We'll send that to you with our kind of variance notes. But I think, the bottom line is that we're factoring in, what we call the ACR, the average commercial rate, which really, boosts our Medicaid, payments. We're also factoring in what we call as the DISH reconciliation. We were overdrawing DISH because ACR and other rates were late, so there's a reconciliation process that we're working through. And we've also accommodated the impact of HR 1, the One Big Beautiful Bill, and within that bill, some things that will make it more difficult to enroll for Medicaid. There's the work requirement. So we factored that in to the analysis, and plan to plan, bottom line, our plan actually strengthened, got better at the bottom line. So we'll have those available soon and, share that.
Okay, and I think our plan and hope is to bring that to the board.
Yes. Yes.
Great.
Yep. But in terms of this year, right, our report, January, we had nearly $600 million in the bank, which is 19 days. Our budget variance, we've been running negative. We're less than 1% at this point. I think when we met last time, we were maybe at 1 or a little over 1%. We feel, comfortable there. We're dealing with the CFOs. We've asked them. We have what we call the STAR report, and we track your performance with these stars. And if you go to 0 stars, right, we're asking them to produce a report, kind of make sure we're on the same page with what the problem is that they're seeing, make sure that we see the same in the data. And then we ask them for, work with them to find solutions. So we're at that stage at the mid-year point. And we'll go through what we're kind of seeing in the data in terms of what's driving. It's mostly overspending. It's mostly an expenditure problem at this point. But nonetheless, we're at less than 1%. We are also seeing some avails develop. We use this term avails. These would be new dollars to the plan that we don't have in the plan. And I think one good example of that would be the FEMA dollars, the 176 million that's been approved. Right, it's already been approved by FEMA and the state. Those dollars are sitting with OMB, and we're made a request, right, to have those dollars flow to us. And there's still the issue of.
I'm sorry, John, you said those are not in the plan.
Not in the plan. So we would call those an avail. That would be our term. Is it would help offset, this bottom line negative. We also keep track, right? There's risk and avail, right? We keep track of both sides. If we see risks develop, we put that on the list, and we see how that. We try to manage it and see if it develops or not. But I think FEMA is one good example. We've sent a note to them, to the OMB, requesting the receipt of those dollars. And those dollars are different than the 100 and how much is 130? Yeah.
136 appeal.
Yeah. So there's 136 million in additional FEMA dollars that FEMA initially approved. I think on a Friday, and then on Monday they changed their mind. So that's under appeal. We still feel pretty confident that we'll get that money, but that's not on what we would call the avail list yet. We're holding that.
And also not in the plan.
And not in the plan.
Right.
Exactly. As we, I think, showed last time is, on the purple chart, we have the purple chart in here, but we're looking at our actual patient care revenues. They actually decreased by, $63 million. We had budgeted in the plan a flattening out. Right, because we're kind of getting, to the top of the tree a little bit. Even though we recognize there's more to be done, but year to year, actuals to actuals, we're down 63 million. I suspect that will turn around as we finish out the year. But we are seeing a decline in inpatient discharges of 2.1%. That explains some of it, plus some other year to year variations. But that's a good chart for us to look at. Obviously, it's got our full attention. The strategic financial initiatives, we set a target of 472 million. We've already banked 148.5 million. we're running a little behind there, but we believe that we will catch up on those remaining efforts as the year goes on. And then there's other things that we're looking at. Average length of stay is a new target for us. We want to bring the length of stay down and make our throughput through the facilities more efficient. A lot of that has to do with patients that are we're in our beds that no longer need medical treatment at that level. So we're trying to find alternative placements and kind of move them through the system more efficiently. And then we have Margie's work, which we've been talking about in terms of achieving best practices on the rev cycle side, and then expanding behavioral health services in ways where we think we can create some efficiencies. So far through November, right, we're feeling pretty good. From a cash perspective, $500 million or 16 days cash on hand when we close February. That'll jump up in March. Our estimate here is $700 million, and that's primarily driven by the receipt of the ACR dollars, the FY 24-25 dollars, what we call year one, is now with the plans. So it's made its way from the approval from CMS. The states reran the rates. The dollars have been delivered to the health plans, and then the next step is they would come to us. So,
Is that going to come in one bolus for the year?
yeah, why not go through
So I think, for each plan, we sort of have agreements that will work with them, but, because it's a retro period, we kind of expect that, many of them will advance the great majority of the dollars in the next month or so. But, Megan, I'm not sure if you want to.
I mean, it's variable by plan. So we don't get one lump sum from, each plan has their divvied up amount of money. So that makes it a little bit more complicated.
But those with the biggest dollar values tend to give us the lump sum.
They do.
Yeah. So Health First, Metro Plus, right, where the bulk of the dollars are, we work out this arrangement where they pass it through to us. The others, right, we go through a process with them. We've asked the state for what was the direction that the state provided the plans, because we like to point to that. Like, the state gave you this direction, they've issued 90% of the money, right? We know that that's really our money, and it should have been ours in 24-25. So we have those conversations with them, and it tends to work out. I mean, I think it's fine, but these are special transactions for the plans, and we ask for their partnership because they have to also reconcile these dollars on the back end. So there's a lot of work that is involved. So we do appreciate that.
So that is going to make our cash suddenly
Yes.
bounce up,
Yes.
right? But on an accrual basis, David, that won't.
We've already, we've accounted for revenue as appropriate per gap.
Right.
And we're crosswalking those two, right? The timing is always important. Year two, right? That's the 25-26. We've asked the state and actually try to, develop a plan that's easy for them to, get a large portion of the money out the door. But the 25-26, which will end in March 31st, we're hoping the state can get those dollars out to us somewhere in mid-April. And we've been speaking to them, and obviously they're very busy too. They know that we're in the queue. We, again, try to develop it in a way that we could streamline the package to get the dollars to us. We're really trying to catch up, and then year three, right, which I think is something we talked about on the next slide, but year three is for 25-26.
26-27.
26-27, yeah, 26-27. We've developed the preprint with the help of Manat, and we have submitted that to the state, so it's under review. So we feel like we're on time. We got that to them early, part of the month. It's usually pretty complete and ready to go. So we'll have to follow that until it gets out the door.
And then, so if that timing gets more in line with the current year, we'll start to see that more just in our regular
Yes.
rates.
Yes. Yeah, again, this also explains why we were drawing dish dollars in years when we shouldn't have been drawing dish
Right.
dollars, because these rates were late,
Yep.
right? So we don't have a choice. We draw the dish.
Right.
And now we've worked out a plan with the state that as they're paying us,
We can reconcile the prior draws, yeah.
Yeah.
Well, hopefully we can get into a cadence
Yes.
where it's more.
It's been something you've heard me talk about
Yep.
since I've been here, so it's
So
hard. right?
making a lot of progress, yeah.
Yeah.
Thank you.
So in terms of managing risks, I don't think anything really new here. We turned a couple to green, I believe. But the essential plan changes. I think we're still fine there. You know, the state cut the essential plan rate. In the budget, I think, you know, the state, I think appropriately is playing essential plan two ways. One, you know, they've submitted a plan to convert the essential plan back to the basic health plan. And there's $8 or $9 billion sitting in an account that they could then draw from and avoid the cut to the EP 1 through 4 group. That would be a major cut. And what the governor proposed in her budget was assuming that the basic health plan will not get reapproved by CMS. She's built in maybe 2.5 or even I think it grows to $3.5 billion to provide state-only insurance to the LESA population. So either way, right, I think the state is trying its best, right, to kind of stabilize, you know, the essential plan program. It's obviously very vitally important, insures hundreds of thousands of people. So we will keep our eye on that one. Medicaid work requirements is still red. Again, this is the impact of HR 1. You know, the federal bill proposes putting in 6-month recertification requirements versus a year, and then there's the work requirement. But there's the opportunity for states to delay that. We've not heard any recent discussions about that, probably because it all, you know, hinges on the first one with the essential plan. You know, efforts there. So that's still red.
John, it occurs to me that we might have some more information about that based on how the efforts go around SNAP. Because SNAP has the same requirements, but they start sooner.
Right.
Right, and DHS has been working to, you know, try to get doctors to fill out disability papers for people who can't work, and therefore the disability works. So I would think we would know in a few months a lot more about how many people are unreachable, right? Because if they make the requirement for SNAP, they should make the requirement for Medicaid.
Exactly. Yeah, and from the state's perspective, I think they run off the same. Those two systems talk to each other for Medicaid eligibility purposes. So,
Which is also good because people always have the need for food, and they only sporadically have the need for health care, right? If they're otherwise healthy.
Yes.
So, you know, if people are motivated to get the SNAP benefit,
Yes.
then, and they qualify, and therefore, you know, we can see that and get them Medicaid, that would be good.
No, I think that's really good. I mean, we have efforts underway here. We call it, you know, the one-stop, you know, benefit, where as we're going through the enrollment process for people's health insurance, we also check to see if they're eligible for SNAP and WIC, and so we're trying to bring our two systems together, and I think, you know, hopefully that'll help, right? As people come to us for healthcare, we can also enroll them in SNAP. I don't think we're going to get to the point where they got to come for SNAP, right? And we'll provide it for them. But we are trying to bring the two systems together.
Sure.
Yeah. So average commercial rate, I think I covered everything.
You covered.
Yep. MCO tax, we turned that one green, I believe. So the state, after the release of the governor's budget, received approval from CMS that the MCO tax could go on for 8 quarters instead of the expected 9 that they had initially submitted, I think, before the Trump administration. So that was good news. I think that threw off over $1 billion for the financial plan, and within the 30-day amendment period, the governor put forward a plan to allocate those dollars as she had promised back out to providers, and there's a pot of money that goes to hospitals and nursing homes. I think it's roughly $750 million state share. So that will be a benefit for us. But again, it's short-lived, right? It's 8 quarters. The state has, I think, until next December to figure that out, which they will, right? It gives them a little runway. So we turn that one green, and we feel pretty good about that. Potential city-state budget challenges, as I said, you know, the governor's budget came out, and so did the mayor's, and we're grateful that the mayor's budget included some investment dollars for Shell and Bridge to Home. and the outlay of dollars to recover the funds for the warming operations. So we very much appreciate that. Those are very good investments for us.
There's a lot of interest in the success of Bridge to Home, City Hall, and a lot of gratitude about the warming operations. There was a very nice New York Times article about, how effective it's been.
Looks great.
We also were informed, I think appropriately so, given the city's, budget situation, that they're putting out a call for savings actions to come, to be submitted to OMB, and we're in the process of developing a list of what those initiatives could look like. And then the government shutdown was averted, and the dish cuts were delayed until September of 2027. So other than that, yeah, we have that green too. So 3 greens. One we don't have a color yet, a red that we have to make go away, and a yellow that I think both points to green. That's my optimism.
But go back, John, the issue with the top one turning green is it'll turn green, but there'll still be, about a third of people who will fall off?
Well,
Right, isn't that,
Yeah.
or has that changed?
no, I think it's the EP5 group, right? That's the one that we don't have a solution for yet, but there's plenty of people thinking about it. I think there's 425,
About 450, yeah.
425,000, 450,000 statewide.
450 statewide.
That's EP5.
So I'm trying to think how much, so does that mean 250 are city?
I'd probably say more than that.
I think
I'd
it's,
say 3/4.
Yeah, 3/4. Yeah.
Okay, so you got 300, let's call it 350 people who are gonna fall off.
Yes.
And they're gonna fall, as it stands now, to nothing.
They will fall to, they could revert back, right, if they were to have employee insurance, but when we've looked at the data, the way that they got the EP5 is they were previously uninsured to begin with. So we don't think that they're necessarily going to fall back to employee coverage or go to the exchange, right? They'll likely, right, fall to be uninsured.
So, and because there's a lot of interest in the question of NYC Care, and tell us a little bit more about who they are. These are people who are legally here, Megan?
Yes.
So they're legally here.
They make between 200 and 250% of the federal poverty level. So they've historically been excluded from a lot of New York State benefits programs that are available because they just make too much money.
And they would be eligible on the exchange.
They would.
And
And they always have.
And isn't there a silver plan that would have no copay for the 200 to 250?
I think part of the problem is that with the subsidies recently being cut, there's just much less federal funding to enable. So I don't even know with the silver plan how affordable the silver plan is
I
today.
see.
Right.
Yeah.
Now, some states have offered to pick up the subsidy, when the federal dollars dropped off. The states have put together a plan where they will fund the subsidy or some portion of the subsidy. There's probably 5-6 states that have put that forward as an option. And there are different proposals that are out there that we're looking at.
Would there ever be a scenario where it would be financially, let's say they fall off to nothing,
Right.
and let's say they're our patient.
Yeah.
Would there ever be a scenario where it would be sensible for us to pay the subsidy and thereby get the insurance?
We would have to run those numbers, and we have a variation of them that we've worked up with Metro Plus. But that would be, cash out of our pockets. I mean,
What I'm trying to imagine is, right, is say somebody is in that group and they have diabetes, hypertension, and elevated cholesterol, and are therefore, coming for visits, right? No, you could, if we were doing it, you could theoretically create whatever criteria you are,
Exactly.
as long as it's equal, right? You could say, you must be, our patient, it must be Metro Plus, it must be, you must have an illness, right? So you could create a set of scenarios if it's ours. So where you could target the people who are likely to cost money. But I mean, I know you have to look at it against Dish and, right.
Right.
But I think, didn't we figure out that you don't really get Dish on outpatients? Or did we figure out you did get Dish on
We do
outpatients?
get dish on, so that I think is exactly what some of the things that we're thinking about. Can we leverage, if the essential plan or an insurance option, or the state doesn't, put forth its own subsidy dollars, could we enroll these folks in some version of NYC Care, right, where they'll get their pharmacy benefit, right, they'll have a doctor clinic they call their own, but then for inpatient, outpatient services, we can leverage Dish. And then the federal government would pay half of the inpatient and outpatient cost. And that's what makes that desirable, maybe even more preferable than the subsidy approach, because the subsidies would be really picking up the full cost of care. So we're trying to figure out, is there a way to kind of have a partial insurance package coupled with Dish, right? So these are complicated things.
Yeah, I would think that the current administration would be very interested in a plan if we said that we put together an insurance subsidy for people in the 200 to 250 who met a medical need.
Yeah.
I do think that, right, I mean, we don't usually model medical, you usually model all comers.
Right.
Right. I think if we're going to do this, you have to model medical need.
Right.
Right. And figure out how much you're going to get if they go through through Dish, because Dish is only going to give you half. Right. You get a better payment through the insurance. But of course, you'd have to pay the premium, and we've already agreed that we don't know what the premium is. So that's another issue, right? We'd have to figure out what the premium was.
Well, we know from our own EP5 data, or Metro Plus's EP5 data, they tend, the EP5, for reasons still trying to understand, more expensive than 1 through 4, right? So it's an interesting group, right? They're 2 to 250% of the federal poverty level, and they tend to be the most expensive cohort of all 5.
Well, let's think for a minute just who's in the other 4 groups. How are the other 4 groups? Remind us, Megan, who's the other 4 groups?
So there would be a cohort who are Medicaid eligible, well, income eligible for Medicaid, but they are in their PRU-call status. So they're
Okay.
waiting that 5 years to become eligible for Medicaid.
Okay.
That is what we call the Aliasa population.
Okay.
So that's Essential Plan 3 and 4. Essential Plan 1 and 2 are for those thresholds that are slightly more than Medicaid. So they don't qualify for mainstream Medicaid. They qualify, I think one group is 138% to 150,
Yeah.
and then maybe 150 to 200. So it's based on their income. And Essential Plan is only for adults, importantly.
Right.
Kids
are all covered. Well, the thing that would make you, the most likely reason that a group is more expensive is adverse selection. Right. I mean, typically that's why if one group is more expensive, it's because the overall group is not only a smaller percentage of going in, and the group going in are sicker.
Right.
So what you'd have to assume is that in that 200 to 250 group, maybe because they're working, maybe because they see themselves more as middle class, they're not applying for these benefits,
Right.
except for the people who are really sick. Right.
Exactly. Yeah, it could be, yes.
So usually adverse selection is the
Yeah.
answer
Yeah.
to why a group is performing. But it fits my theory that if you were going to do this, you would do it with a medical indication, not just, to recycle the money.
Right.
Right. But really to say, create a set of criteria where we really believe that medical care has a discernible difference.
Right.
Right. And let the other people, go to the EDs for their ankle sprains and bad coughs. But the people who have diabetes and hypertension, where, there's really value to an every 3 or 4 month visit.
Right.
Right. Because we really have something to offer them, move them into it.
Right. Yeah, we'll look at all options here. I think it'll be very important that we move quickly, because I think this issue, once it happens, it's going to happen pretty quickly. and then we'll have to, we feel like from the dish perspective, we've kind of set ourselves up nicely because we're using ACR and we have a big bolus of dish dollars
Right.
available to us. So when the effects of HR1 happen, whatever that plays out, we will have enough dish dollars to fall back.
Right, it's just that the dish is only 50% and sometime in the future.
Yeah, but 50% is quite a bit of money.
Right. No, well, everything in here is, absolute dollars is
Right,
huge because
right.
of our size.
Right.
I'm just trying to think, I mean, I guess that's the question, you're absolutely right. If in the end, the dish, 50% of the dish is better than the insurance payment minus the subsidy you have to pay,
Yes.
then really the goal for us should be more about how to turn NYC Care into something that looks more like insurance even than it currently is.
Exactly.
So that we can really, advertise it as,
Right.
a benefit.
Yes, that's kind of where we're going. I mean, we're trying everything, right? Everything's on
Sure.
the table, right? And we have a lot of, the advocates have a very nice paper that they put together laying out these options and fiscals. Elizabeth Benjamin and her team, right? So
Right.
everybody's kind of, positioned. A lot will happen because I think CMS is supposed to make a decision sometime between now and the time the budget is supposed to close in April, so that they don't have to. They could delay that, but that would certainly really provide a lot of continued resources to pick up the 1 through 4, and then that would leave how to deal with the 5 group.
And just for the board, it's still true that when the basic health plan reverts to Medicaid, the plan takes a huge hit, right? Doesn't it? Don't we believe that the Medicaid rate is significantly below?
No, well, that's the EP rate is significantly higher than the Medicaid rate today, right? And the cut that was taken a couple months ago was to actually bring the EP rate down closer to Medicaid for
I see.
inpatient, outpatient. So they've already made that cut.
I see.
In part, that makes sense because this basic health plan, the $8-9 billion, is a fixed pot of money and it won't grow. So the state has to make sure that those dollars will carry them 2-3 years, or as far as it will carry them. New monies are not going to come and backfill.
Right.
So they have to make those dollars last. So it does make sense to be a little bit more prudent with the rate setting. Again, as long as we can, get access to that basic health plan, $9 billion. And I think there's some estimates that could carry, we could cover the 1 through 4 group for 2, maybe even 3 years. So that would be the first thing, and then that would still leave the EP5 uncovered, taking us back to how do we address their needs. It's complicated. It's a very complicated budget, right? They're in a matter of weeks, right? The state and the legislature are going to have to figure out how best to kind of position themselves here, with a lot of unknowns really coming from the federal government still. I think everybody's, trying to do the best they can with what they know.
Interesting.
Yeah.
It is.
Yeah.
Interesting thought, Mitch. Should we move through quickly on the FY, where we are through November?
Sure. Good morning. Micheline and I will take you through the variance report or the variance updates through November. We ended the period with a variance of negative 58 million, less than 1% given the size of our budgets. Receipts are below budget, driven by the direct patient care. However, it's partially offset by strong risk performance for the period, and we're doing better than target there. Our disbursements exceeded budget, and it's above as we continue to refine our staffing models and manage our overtime spend. And we'll take you through those details on the PS side on the next. We can go on the next slide. Okay. On our variance drivers, inpatient, outpatient, our billing is very close to target. We're seeing our ramp up efforts starting to come to fruition after Q1. Our slight variance is due to the timing of some receipts that haven't come in yet and the work that we're doing on new initiatives that are still ramping up, primarily in our length of stay efforts. Risk pool performance is 9% ahead of target primarily due to the timing of payments and prior period updates or adjustments due to Metro Plus payments that came in Q2. And our other revenue categories, including grants and intra-cities, were slightly positive, though there are some variances due to prior year recoupments that we received in the period, so for some appeals and settlements, but that was offset by the timing of grants that we haven't yet received, but will receive towards the end of the year. So we're doing well in that category. It's just we're expecting to catch up by year end.
Good.
On our expense side, this is where it's a little more interesting. We're above our budget target by 1%, primarily due to overtime needs and our non-model staffing areas. Our PS is over in overtime again in our environmental services, facility support, and nursing services. We've had our Q2 OFD all hands on deck recently with our facilities, and they're working on their individual facility improvements to reduce overtime spending, working on the different workflows to approve overtime prior to having them being performed at the facility. So there's work to reduce that overtime spend, and that's primarily the focus that the facilities are working on. Our discretionary spend is on track. This is a huge improvement as our reliance on temps have gone down, so our net discretionary, our OTPS budget is right on target, and we're working to catch up on our AP payments, which have improved year over year, and we're seeing efficiencies throughout the system, and facilities are also working on their cost avoidance as well as their overtime to keep the OTPS spend down.
When we're presenting this, you might think that really the purpose is to show you that we're off. Really, it's a testimony to how good your budgeting is. Right? Because we don't assume when the personnel cost or the discretionary spend is above, our first assumption is the budget's wrong. Right, because the historic health and hospital budgets were somewhat fictional. It's only under John and his teams where the budgets have actually come to reflect what the actual expenses were. The original budgets were just historical documents. They really had no meaning in the actual what people were spending. Some hospitals would be over budget and some hospitals would be under, but it had nothing to do with the performance of the people there. It was just whatever the budget was set for whatever reason and whatever year it was set was the budget, and nobody tried to change it. John and his team have been working very hard at trying to have accurate budgets. So then you could really have a meaningful, gee, why is this over? So when overtime costs are over, for example, you have the first one, overtime costs in environmental services, right? So to us, that doesn't mean that people are over approving environmental services. It means we have to look at environmental services and ask ourselves whether, in fact, we have the right amount or we don't have. So either it becomes a possibility. But to me, given the size of our budgets, these overages are really quite small.
Yes, I mean.
Right, and way different than before. And again, the goal is to have, John does not with his team start with, you have to cut your budget, right? We start with what is a realistic amount of money that you need to provide the services we're asking you to provide. And then the overages then become the question of, okay, so you're using more than you need to use, or do we have to correct something in the budget in order to make it more accurate?
I would say that's true. I mean, it's not just the overages, but the underages. With the
Right, yes.
Budgeting is very precise. We're never more than a percent. Well, I don't want to jinx it.
We say we make our living in the last 1%.
Right.
The 99% we're supposed to get right. But I think we appreciate that, Mitch, because we were talking about kind of where we are with the CFO's STAR report. Those that are running negative on the margin, right? We asked them to provide to us an explanation as to why that is, right? And we can now have that conversation. Like, we can all look at the data and draw the same conclusion, like why are we having a problem? And then the next step is, can you give us some ideas for solutions? And that's the step we're at with the CFOs, and we have a conversation with them tomorrow. But we have to be able to explain the problem, right? And then we can figure out what's the best
Right.
solution.
It works very well on the expense. It's much harder to do on the revenue, because both the variety of ways we get revenue and sometimes the delays in when we get revenue, right? So, you can't exactly hold a hospital CEO, to how much dish is going to come in when we can't even always predict how much dish is going to come in, because it's about 3 years ago, and how big the pot was and how much did everybody else ask for, and right. So but the expense, people should be able to say yes, we really need more environmental services, or no, we just approved too much overtime and we need to be tighter, right, on the overtime, right? People approve overtime because they need it and because a friend of theirs, is struggling making his rent. Sure. I mean, it's real life, right? There are a lot of people in New York City who need overtime to survive and pay their rent. And whether or not you, as a supervisor, if you know somebody needs overtime, are you more likely to approve it if you think that they're a good worker and they need overtime to pay their rent? Probably.
Yeah, to Dr. Cass's point, this year we promised the committee before to rebase the budget for fiscal 26, which we have done. So now, when you're looking at these variances, we're actually able to explain more than just like there's more to be adjusted as we go with modifications. So if you notice, we're having less of these conversations, and now we're kind of pinning down really where those variances are. And on the revenue side, definitely we're looking at these pots of money like pools and these other components in their own bucket. And the part where we are having the discussions really with the facilities is on the pure inpatient, outpatient revenue, as well as their expense against budget. So the conversations are much tighter and more meaningful to them. We continue also, as it says here, working on our staffing models, which have been extremely important for the facilities to assess like where they stand. And we've made, great improvements, I would say, especially on the nursing side and our temp reductions and the hiring there. So, there are a lot of, I would say, good stories baked into these numbers to definitely be acknowledged. And you'll see more of that on the revenue. I do want to say one quick point on the year over year, which I know we covered in the beginning, to the point of timing also. And we'll talk about that a little bit later, but there's actually also a very good story baked into the year over year. Because of the cash timing, what's driving the negative is really mainly the Change Healthcare dollars that we got in the first part of the year last year in fiscal 25.
So it inflated, right?
And UPL conversion timing that we got more of in the first part of the year. So there are two big timing stories there. And so although our volume is down, which impacts in the negative, but our our collectability on the rates side, and also our CMI is high. So we're actually if you adjust for volume, if you adjust for the timing of UPL and CHC, we're actually positive 50 million. So I think that story is also important to call out there. But yeah, we still are looking at our net margin and the actual side, and we still, even though there are timing factors, we still strive to look at that with our facilities. And John mentioned the Avail also with the 176 million, which is not baked in our budget. It is in our financial plan, but not in our budget. So we can use it at some point to even holding ourselves accountable to the actuals in a cash world, which is even a tighter, or higher standard, I would say, that we're holding ourselves to.
Great.
Wait, I just want to go back for a second because I've been thinking about it a lot. This issue of overtime is a very problematic issue because we as managers see it as a negative, right? But we have many low-income workers for whom without overtime, they wouldn't be able to pay their rent. And how to deal, and I mean, it isn't our job to try to understand people's finance. And it's certainly not our job to approve overtime if we don't need overtime. But it is important to note that in our organization, when you cut down overtime, people get very agitated. And I don't know exactly what the answer to that is.
Oh, to
But
see
if
that in the
people have
staffing.
well, because if people expect a certain number of overtime and have gotten that and have baked that into their life budget, then when you suddenly say, well, we've come up with a new model, we're so proud of ourselves, now there's, we don't have to do overtime anymore. Now you have a bunch of people who are really pissed off because they can't pay the rent.
Yeah,
Well, what-
we do try to create enough flexibility, you can make that choice. Like, do you want to fill that vacant position, or do you want to just do more overtime? Right, those choices are important, and and we try to, same with the physicians. Like, do we want to convert sessional hours into a full-time equivalent, or do the doctors just want to work more hours? Right, we try to create those choices.
Right.
Yeah.
Well, I worry less about the doctors
Yeah.
in terms of whether or not they're paying the rent, but
Yes.
Well, but then the
But the
question becomes, what's the right wage? And having, because from a financial management standpoint, you have to have stability, right? So if we know what the staffing needs are and what the wage is.
I think one major positive we've made actually is focusing on our own staff, like filling in for the non-productive time or orientation, things like that, as opposed to temps. So that's dollars going into our own staff's.
temps we don't want.
Right,
I mean, I think
exactly.
that's,
So that,
registry we do
Here.
not want, temps we do
right,
not want.
so that's been actually a major step that we've,
Which is what Patricia says as someone who's had to deal with
I just, the CMI increasing to me is very important to overtime hours. And if you notice, it's nursing and environmental. So to me, that's directly proportional to the care needs of the patients. So if that's where our money's going, then it's a good thing. It's not a bad thing, right? Because you need more nursing hour care, not just the RNs, but all classes to help that patient. Because the higher the CMI, the more issues they have that they need contact, right? And then environmental, because they're going to have to keep cleaning up. I mean, you already know, the longer the patient's in the bed, the more issues they have. People are not caring about where they're throwing things when they're caring for the patient. So to me, it's directly proportional, and I'm not that concerned, considering that the numbers are not, abhorrent.
Yeah, no, we appreciate that point. Even like if we're trying to turn over the beds more efficiently, right? Those beds need to be clean.
Everything
Laundry
has to
needs to happen, right? Those things have to be taken into consideration. And we try our best there. But yeah, the CMI is also another very important point, right? The needs are going up, right?
yeah, the facilities have been really doing a great, honestly, tremendous job staying, even with overtime, like where we have already the models are specifically on the inpatient side in terms of they're still staying within their models. So we definitely have that level or appropriate nursing coverage. There's no, I would say, anything about keeping that down in relation to what the needs are, because the models are also driven by our census. And definitely to your point, the CMI, which is in the context of what type of units are being covered, is baked.
But Natalia does want the CMI adjusted into the model too at some point when we can do that, I think. So that's right.
That's something
yeah,
we can
yeah.
figure out how to.
To get it into our staffing model.
It's very important
Yeah.
because that's also very important for the nursing care hours. And if we don't account for it, then we don't see
Yes.
why the overtime is there.
Thank you.
Okay, and so this 63 million, as you heard, is very layered. Though our discharges are down, our visits are up, our CMI is also higher than it's anticipated. And we're seeing this 63 compared to last year, net number with some improvement in our rates and just the cash timing of what came in the first period of this year versus last year at the same time is slightly lower in those supplementals and other cash dollar recoupments. Compared to budget, we're on track for our inpatient, outpatient initiatives, and we're still ramping up. We're in March now, but we're still working towards meeting our targets by June. And again, compared to last year, those are our our metrics, and we're seeing the trend continue into December. So we'll be happy to report on December when we do that.
Great.
Okay. So I've talked about this before, but last year, as we were preparing the fiscal '26 budget, one of the things that we'd looked at was trying to determine how to get all of our facilities into what we would call best practice revenue cycle performance. And we looked at 8 metrics. We chose these 8 metrics that we identified as the sign of a healthy, high-performing revenue cycle. And we said if each of the facilities performed at the highest level of our internally best practicing facility, so we looked at internal best practices and then calculated the gap across the system to get to that best practice. And what we identified is $200 million in opportunity if each of our facilities improved their performance to the internal best practice. Some of these were relatively smaller targets, so things like denial rates related to eligibility and authorizations. We had done already quite a bit of work in improving those metrics over time, so those targets were relatively modest. We had, some significant opportunities on aligning our patients with their PCPs and bringing more risk dollars into the system. Some opportunities on the timeliness of coding as well as the quality of our inpatient coding. And lastly, what we would call outcome metrics, and this is where we had the largest opportunities in improving overall our AR days and what our insurance net collection ratio. So the rate at which and the completeness at which we collect from insurance companies. We put $54 million of that $200 million into the fiscal '26 budget. We're putting the rest of it into the fiscal '27 budget, so that our expectation is by the end of fiscal '27, all of our facilities will be at this internal best practice. And in many cases, this internal best practice is at or exceeds the overall Epic client base of best practice. There will be still some room to grow after that to get to the overall, all of the facilities at the Epic best practice. So on the next slide, you'll see that through January, so we're a little bit ahead of where some of these other numbers are. Through January, we've achieved $45 million of the $54 million target. So most of our the large numbers and achievement have really been in improving that insurance net collection rate, improving our AR days. And, the themes are collaboration, implementing standard work. We've worked over the last several years in developing standard work around a lot of these workflows and just ensuring that they're implemented consistently across the facilities, having the facilities work together. We're strengthening those collaborations so that if, one hospital does particularly well in one metric, their sister hospitals are going on site visits and learning from them. We facilitate a lot of conversations, but hopefully, they're really learning from each other and how to, on the ground implement. Some staffing reorganization and building up to some of those staffing models. There were areas that were understaffed and facilities have really doubled down on recruitment efforts and continuing to drive on root cause analysis, just really understanding what are the underlying issues that we can fix and helping the facilities individually, collaboratively, however it works to fix the problems.
This is consistent with Mitch talking about having good eyesight on the expenses, the same thing on revenue generation.
One idea that's been raised that would be a new thing for us to do, Margie, it affects you, it would affect other parts, is to try to schedule doctors for closing notes. It actually was first raised about training, which I thought was very sensible, right? One of the doctors in the leadership position, and I thought very sensibly complained how, we have like these trainings and like periodically we send out a notice and say to all doctors, you must do this training by the end of the year. right? You must, and he correctly said, why don't you, at the beginning of the year, say what are the trainings? And then I'll just book my staff, for doing all of the trainings so that it's people's jobs. See, what we tend to do for clinicians is we say, your overall job is to do this many clinics, close this many records, do this number of trainings, blah, blah, blah. And what he's saying, it would work much better if you said there are 6 trainings, and then I'll just assign people no patients during that time and to do the trainings. And I was thinking, maybe we should do the same about closing records, because what it would change is if you said to a physician, from now, normally you saw patients from 9 to 12, and I don't know, we'll just make up numbers, you saw 8. And now we want you to, from 9 to 10, close records, and from 10 to 12, see 6. Then the clinician has no excuse, right? They've been assigned an hour to do the records, which is generally not how most things just function as, your total job. Now, of course, the problem is that, right, then you're decreasing, but maybe in some you would get more dollars if you did it this way.
So,
Right, but proper documentation, and what it changes. See, even the more inspiring doctors will often have very large, unclosed charts, because what they'll feel is, well, I always put patients first. I spend as much time, so then I have this backlog, and it would change the dynamic if everybody said between 9 and 10, this is your job. Right, and so then you completely remove the issue of, whether or not you want to prioritize this.
it's a thought, we're really trying to attack this in multiple ways, coming at it from all angles. The good news is that in the last 12 or so months, we've reduced open charts by over 60%.
Yeah, you've been
So
phenomenal.
I have not reduced a single chart. I promise I haven't signed off on any. But, our team has really been working with the facilities, talking to doctors and understanding what their barriers are, so to be able to really work through those issues. So if there are some doctors, I think in some practices, what you say makes a ton of sense. Really busy, where you see lots of patients in a couple of hour blocks. Some other practices, it might not make as much sense to do
Right.
that
It
way,
wouldn't
but-
be right.
Yeah.
It would
But
only
we've
be
heard
sensible
everything.
where it was sensible.
Right. We've heard everything from doctors. A lot of times it's not about the time, but sometimes it is.
Right. No,
And
it's
so-
totally depend. Like one of my friends, who's one of our very dedicated, surgeons, texted me to say she's having a quiet day on call, and she's like closing 80 charts. Right. Which is like a good news, bad news kind of story, right? She's the kind of doctor who would always put a patient first, and she's conscientious, right? She's not quiet day. She's like, oh great, now I can close those 80 charts, but that isn't really what you want, because I don't know how often, since she's a trauma surgeon, she has a quiet day, right? So those
good
charts
news,
will
bad
just
news.
wait until she has another quiet day. But maybe some of them will be post-date, right? I don't know.
Yeah, I think the affiliates have been really good here, partnering with us on open charts and training, right? We actually, I think, created some incentives, right? If they close the open chart, right, their pay comes out of the FPP, right? And I think what we've discovered is it's more about like wanting to be a good member of the community. That's the domain we've called it, right? But once you put the name up on the board that you're behind, right, and everybody sees it, that has an effect too, right? Like nobody wants to be on the board, right?
Well, and Mara sent me, all the providers at Gouverneur, a clinician to clinician Excel spreadsheet on Friday with everybody's open chart. I had very few.
I've never seen your name pop up on a list.
No, I close all my charts.
See, it does work, right? I just say if we can produce the list, right, which is good because we can have the conversation if we can produce the list. And
Yeah, now they can
Carrots and
produce
sticks.
the list.
Yeah, that's great. Thank you. Anything else on revenue cycle? That's great. Megan?
Okay, so one quick slide on our BBP strategy. So as we were talking before, you know, we're worried about those folks who are losing their eligibility for coverage. This slide is talking about those patients who are eligible for insurance, and not just Medicaid insurance, but enhanced Medicaid insurance. And so what can we do at Health and Hospitals to try to facilitate them getting a richer benefit package that has a twofold benefit. One, the patient will have access to more services, and two, the health plan will have greater premium to pay their claims. And so when we are in our value-based contracts, because we as the hospital system are taking on risk, we can share in that surplus with the insurance company by getting them a richer premium. So this is just flagging in this fiscal year. We are definitely working on telephonic outreach among some of our staff at different hospitals. Specifically, some of our CHWs have been trying to specifically do some outreach to members who are eligible for a special needs plan because they are currently experiencing homelessness. And so we have had a targeted list from Metro Plus of these patients are eligible for this coverage, and let's see what we can do if we can try to get them on the phone to change their coverage. For several years, we've been doing work on identifying Medicaid members who are eligible for a health and recovery plan, or HARP, because they have 2 or more chronic behavioral health conditions. You can see in the chart here that we had over 1,000 conversions of those members in 2025, and we still have folks that we're working on in 2026, and that is a $45 per member per month surplus increase. On the Medicare side, there are patients that are in Medicare, are dual eligibles, meaning that they have Medicare and Medicaid eligibility, but they also need long-term care supports. And if they can get into a fully integrated insurance plan, they get the maximum benefit package. So there's a large opportunity that we've been exploring, several thousand patients that do qualify for this enhanced product. And that's worth about $372 per member per month in surplus. And as I mentioned before, the special needs plan, we have historically been targeting those patients who have an HIV positive or AIDS diagnosis, that they can have access. They get a special support care manager to help them, a coach, I think they called it. And you can see that the financial benefit there is close to $900 per member per month. And so that work continues. We're trying to develop tools in Epic so that we can flag at the point of care that these patients are eligible, and doing more training.
Megan, do we have people cited at the safety net clinics?
Yes, that has been
There's somebody who's physically there, because they're high volume homeless.
Yes. So we've been doing a lot of work to try to make those connections, that even having folks make the connection that if a patient is in adult primary care, but they would be eligible for the safety net clinic and maybe better served there, not only is it about changing their insurance, but trying to make that soft transfer to the different.
What about at the show vans?
The show vans, we've also engaged them. I think, one of the limitations we've had is, we've been trying to focus this just on our Metro Plus population, and, the show vans and the safety net clinics could be reaching patients that have any kind of insurance.
Of course.
So that has been a little bit of a limitation that Metro Plus really wants us to keep it focused on the Metro Plus patient population. But we're working through that. And we're trying to figure out all of the different service areas where we might be encountering homeless individuals, that we want them to be trained and understand that this is an opportunity for the patient.
Megan, different topic. Have you yet had much interaction with your counterparts at Maimonides?
A little bit. I have talked to the managed care lead who does all the contracting, and really trying to understand. We haven't seen any of the terms of their contracts yet.
It's right. It's the legal issues make it hard.
Yeah.
Until we're one thing,
Can't share all information.
we can't share all information because people have signed agreements that say they won't share information. But some things, like you can share like with you can share, here are my vendors, but you can't share, here's what I pay
Terms
them.
are, right.
And you could share, here are the insurances I do, but not what the rates are.
Right.
But it would be, I assume there's tremendous overlap with the insurers.
Yes, very much so, yes.
Right. And so then do they have any types of arrangements that are different than ours that you're aware of?
I'm aware of they have an IPA, which is more complicated, that a lot of their value-based contracts are through the IPA, which is Maimonides is a participant in the IPA, but many community groups are also providers that are participating in the IPA. They also have the ACO that we've talked about,
Right.
which is separate from the IPA. So I know, for example, they have a value-based contract with Fidelis that runs through their IPA as opposed to Maimonides proper.
Remind me, what is the advantage of an IPA in that setting?
I think it is just a larger universe of primary care physicians to build the attribution, as opposed to just having it be at one physical hospital location. So, I mean, also the thought process would be you could coordinate care. If you have specialists, if you have nursing homes in your IPA, you could financially incentivize them. And if you're doing a good job, you can share in those savings.
I see. So presumably the plans are contracting with the IPA. The IPA is taking the risk.
Correct.
And then the IPA is paying out the providers in some.
Whatever they might earn in incentive dollars, quality dollars, then they would have methodologies to disperse that money.
We'll all have to learn a new thing.
We don't have an IPA.
We do not have an IPA.
We did try.
We have an ACO,
Right.
but ACO limited to, as all ACOs, the Medicare fee for service, a declining population. IPA, I mean, we could be an IPA, I mean, there's nothing that precludes being an IPA, but because we haven't really had a need to be an IPA. I mean, one of the big differences as we keep getting into Maimonides from a financial point of view is we've always had more patients than we could take care of. They're always focused on how do we get referrals. Ideally, how do we get referrals of paying patients?
Right.
Right. So they're all about trying to increase volume. We're all about trying to meet the need, which for us is infinite. So it's it's very interesting to try to adjust mechanisms and to figure out, what then makes sense as we go forward together.
Right. Interesting. Well, this is not, we're not going to go into
We're not gonna solve
that
that
today, yes. But anything else, Megan? Any questions? Other questions or comments? I just want to say, again, very, very comprehensive. I'm glad we had the time to go through everything in depth. A lot of things coming at you guys as always, and listening to all of the initiatives, the focus, the efforts is really impressive, and I'm glad for the comments from the committee members on bringing out just how great this work is. So thank you, and I will leave it at that. So is there any old business or new business from committee members to bring before the committee? Hearing none, there be no further discussion. Meeting adjourned. Thank you.
Thank you.
This meeting is no longer being recorded.
This meeting is being transcribed and summarized.